Sir, you are live.
A very good evening to all of you on a Monday evening, which is a very motivated Monday evening. All of you must be completing your final outpatient department work, getting back home, grabbing your cup of coffee. And we have a unique program for you today, which is minus any slides. So there are no slides for you. It's all about a very cool conversation, taking you forward to very high level. The entire aspect of we having been taught, we have read, and we have been practicing what we are going to speak today is actually from the practitioners, from the performers, and from the preachers under Hippocratic Oath, who on this very stroke at 7 p.m. are getting into something which will be very subtle, which could be sometimes surprising, and which could be strong statements which could help us to move our subject to very high levels. From bladder wellness, what was our initial plan? Because we were on this important aspect of World Continence Week. We expanded ourselves and looked into this important concept of pelvic health. We're looking today at female pelvic health and wellness. So when we look at that entire aspect of this subject, you've got successful and beloved leaders who with their body language and with their smile and with conversation will take the subject forward in the way that we all have been actually practicing. We have at this point in time 261 colleagues who have joined in from pan country, from both the specialties. And therefore today we are partners to two ladies who are in the panel and the expert panel. And I would like to take a few seconds to introduce them before we move forward. To start with, sitting in her music room is motivated Dr. Meera from Chennai. Vanakkam, Meera.
Fine, sir. Hello, everyone.
Good to see you. Meera is an obstetrician and a urogynecologist and a robotic surgeon at the Apollo Hospitals, Chennai. She has got a very long pedigree to actually talk about, and I will come to it at some point in time. Dr. Meera, thank you for agreeing to come on pelvic health wellness issue. That is what it's quite a forte of yours, and you've been practicing and preaching that, and glad that it will come from directly from your mouth today.
Thank you for the opportunity. Thank you.
Thank you, Meera. Dr. Vidya, welcome. So to start with, Dr. Vidya happens to be an obstetrician, gynecologist, and infertility expert in the Nanavati Hospital in Mumbai. And thank you for being on the panel today. You are sitting at your office having completed your motivated Monday consultations. Thank you so much.
All of you.
Good evening to you and good evening to all of you. And then we have to partner the two ladies, our two Sanjays, and we are partners in pelvis with urology. So we look at Dr. Sanjay Sinha, senior consultant urologist and kidney transplant surgeon at the Apollo Hospitals, Hyderabad. Dr. Sanjay, good evening.
Thanks.
So while we're moving forward to this very important aspect of success in pelvis that we have achieved as practitioners of the art, and saluting all the audience from pan country, I've been told you are logged in from cities as far east and as far south, as far now north and west, which looks very motivating to us to take it forward around. So it's a question and answer session. The bonus is that you have your questions at any point in time, you can shoot it. We'll look at how to get all the questions covered at some point in time. Therefore, the good news is each of you are pilots in your cities, in your clinics. The bad news is we have only 90 minutes to go. And therefore, we start shooting it. We start with Dr. Meera. Dr. Meera, it's such an occasion where you have been working on a subject which not many gynecologists may have taken up. And therefore, today happens to be quite an epoch-making movement where gynecologists who have been hesitant, or been on the fence on the subject of fecal incontinence, anal and bowel problems in female health, will take it forward. Remember, for all women in this country and world, women go to practitioners of the art in the pelvis and perineum, where you both ladies do a great work around. So to come directly to you and ask you the first question of the day is, tell us about everything on the start of a fecal incontinence as a patient presents to you. You have a case for a robotic surgery lined up, which just leaves the room, and you have an obstetric case lined up, which leaves the room. And suddenly you have somebody who comes in and says, I am going through this trouble of fecal incontinence, and this is a presentation that the patient comes with. Can you just take her through that? How will you probe her as she walks into and handhold all my colleagues in gynecology who are going to watch us today on the subject?
Sure. I will give you two examples. One is a doctor herself, an anesthetist who retired and from Madurai, who approached me in the postmenopausal stage for postmenopausal bleeding and was not forthcoming with this problem. But however, when, as we were discussing, as it is my routine being a urogynecologist to probe into matters of incontinence, specifically urinary and fecal incontinence, as well as the sexual health, because I go through the questionnaire, she said, interesting that you have asked me. I've had a forceps delivery for both of my babies, and I had a complete perineal tear, which is a 4-degree tear, after my second baby. And I felt too embarrassed to talk about it to anybody. I have left it. And I've never been to a gynecologist. I've never had a pap smear. She approached me for postmenopausal bleeding. So this is an anesthetist who, out of sheer embarrassment, did not broach on the subject herself. What she had been suffering from is secretly wearing diapers to work. You can imagine how an anesthetist in a private practice in Madurai would be, and was suffering with fecal soiling. Because of our ablution practice, as in India, they don't use tissue. So obviously this was masked, and she's been having fecal urgency. The reason she broached about it was me probing. And the second point is she has to go and babysit her grandchildren in the US, and she's worried sick that she has to make a 24-hour travel by flight, and diaper would be a nuisance, and so would be the toilet, because the ablution practice is different. Such is the presentation. So you can imagine the amount of inhibition from viewpoint of women to come forth, even to women practitioners, unless we actively probe on this subject, which is the message out here to our dear sisters and brethren out there practicing either specialty. Unless we probe women on the sensitive topic, which even the elite and the educated find it embarrassing to disclose, even to her own daughter and spouse, we can't get it out of them unless we broach on the subject ourselves. And it is just like domestic violence, just like sexual abuse. These are sensitive issues. Unless we are discreet in asking these questions, we will never get to the bottom of this. The second patient got her information through internet and approached on Skype consult day before yesterday, has had a forceps delivery in Bangalore, and had leakage of feces after 8 weeks. And she's had a 3rd-degree tear, which has been missed at the time of forceps delivery. And she needs treatment.
God. So A for anesthetist, A for anguish, A for agony, Absolutely. A for all that. Good things take time. It took time for her to reach the right place, and I'm happy that we are moving forward on this very subject. So the presentations can be variable, and somebody going through something else could be presented. For example, there's also a possibility that you would examine a woman after you've talked to her for 10 minutes, and you'll find that she is in diapers. Unfortunately, not uncommon in this country. And you find that there could be a fecal loading or maybe a wet feces out there. Another way of presentation that, so you've taken us to 2 ways, and I just added another way, which I sometimes see in elderly men, which we don't get to see.
Yeah.
So if that is what, Dr. Meera, that you already warmed us up on a Monday evening with such scintillating presentation, scary about that, respect to the doctor who actually came in around. Tell us, how do you diagnose it? Because is it just irritable bowel syndrome? Is it just an anal incontinence? Is this a sphincteric issue? We just go ahead and handhold our colleagues into this Q&A of diagnosis across the table.
Sure. Before we even touch her, we would concentrate specifically on the history. So any Paris women would be subjected to the insult on the pelvic floor. One would be her pelvic organ prolapse. One would be on the bladder. Third would be on the anal canal. And the fourth will be female sexual dysfunction, which is what the panel is going to cover. So our probing should be on every single aspect of pelvic health. And specifically in somebody who is this old, specifically ask them for urinary control as well as bowel control. Not just a fleeting questions, bladder, bowel, NAD. Or bladder, bowel, okay. That would not lead us anywhere. Yeah. Discrete question as, are you able to control your stools? Are you continent? Do you leak even before going to the restroom? Do you find your undergarments soiled? Does it happen when it's form stools, when it's liquid stools, or are you incontinent to flatus? Does it happen all the time? Does it happen when you have certain types of foods or when you're stressed, which will give me a pointage about irritable bowel? And generally probe on alternating diarrhea and constipation, blood in urine, blood in feces, as well as assess a neurological status as she's entering. We will ask, from the point of view, we will know about her memory and disorientation and things like that, because we do find elderly women doubly incontinent as well. And specifically on the obstetric history, where how old are the children, whether it was a traumatic delivery, prolonged labor, forceps more than vacuum delivery, whether there was any problem thereafter. Many of the women would not have problem there. They would report symptoms much later on, much after the second or third delivery. That is the point to be clinched.
Got it. Thanks, Dr. Meera. I think I heard what all of us wanted to hear. The agony that you take across the table in the first few minutes, reassuring the patient that you have reached the right location. As I said, good things take time. She reached you, and possibly both the ladies must have and will go through that whole workup. And we'll come to that as we move forward. Let me come to you, Dr. Vidya. This is regarding a complexity of a subject which gynecologists would again be privy to, because, as I said, women will go to women for all their problems around. And this important question is about looking at, we always talk about male sexual dysfunction, men matter, but there's something called as female sexual dysfunction too. And with you being one on the obstetric gynecology side, other being an infertility expert, you look at A to Z on this younger women who come to you premarital and just married and beyond. Will you just take us through on this kind of a thing? Is it so common? Are we living at a situation where you find, or gynecology colleagues in India find that? Is it a hush-hush kind of thing around?
Yeah, I think as you very clearly said that the male dysfunction is very clearly talked about. The female sexual dysfunction is really overlooked. I would say underrated in India. As Dr. Meera very clearly said that an educated anesthetist could, have inhibitions. It's the same with the general population. They have a lot of inhibition when it comes to sexual health. And this is where we meet, like in my practice with infertility. Probably it could be a cause of infertility. Or maybe because of the treatment of infertility, there is a sexual dysfunction that just generates, because the number of attempts that they go, they fail through the cycles. And that psychologically somewhere impacts their quality of life, and they're not able to sexually enjoy. So all this impairs. So yes, of course, almost 40%, it's as prevalent as 40%. So 1 in 4 women could probably have sexual dysfunction. And maybe about 10% of the patients will show distress, who will actually come walking into your chamber with a sexual dysfunction as their complaint, but invariably they don't really come directly. They come with other complaints, and then, as Dr. Meera clearly said, that probing is so important. As you probe in, and that's when you go into their bedroom stories and they come out with the fact, and these women generally look very distressed. So they are not open, and that's where we need to have an open conversation. We need to let them know that sexual health is a right of their lifestyle, So yes, we do see a lot of women, especially the educated class are coming up, but the uneducated class somehow don't realize what is sexual dysfunction. So in this cases, we need to probe in a little more.
So rightly underreported, therefore underdiagnosed, understudied, and undertreated, sadly, because it doesn't come out. And you're talking about a metro city like Chennai and Hyderabad and Delhi, Mumbai. I'm not sure what happens in more conservative locations around. So that's something which will come to you. I would just move on to our panelists. So we move on, ladies, to something of a different aspect. Let me give you two important things before I go to Dr. Sanjay. There are two important secrets of his which I have been following very closely. His favorites on the coffee is AeroPress Araku ground coffee, which he takes in the afternoon. And I remember on 11/11/2018, if I'm not mistaken, that very Sunday morning, I woke up early in the morning. It was dawn, and when I took up the phone, the tweet was about him taking that long day Sunday to finally get the preamble to the draft completed for what now stands as India's first guidelines. And that is the time when he was having his favorite vanilla cream spice tea. Dr. Sanjay, thank you so much. So there you are. So we have the chair of the first
By the way,
incontinence
Araku
guideline.
Valley coffee is a treat.
It's a treat.
Awesome.
Yes.
So I think you're giving us more information today, and we are activated by that around. So good enough. So when we look at this entire aspect of storming the history of guidelines by coming up with something new altogether for India, I think glad you chaired sessions, and we had stalwarts who got into that cocoon where you people worked hard, met in various conferences, cities on the sidelines. It was quite awesome. But today we have something of our own, which actually is transmitted to urologists from Jammu to Nagarcoil and from Assam all the way till Jaipur. And it's also time that Dr. Sanjay has taken upon himself and the team, the entire team, which was a part of the team, looked at and agreed to go on to gynecologists, our partners in pelvis, and made the subject more clear and more simple for them. So to open it up for Dr. Sanjay Sinha, there are many young urologists in this audience today. I can see that I have been given an information, and there are many young gynecologists who actually are trying to take up niche areas for them. Incontinence has never been, unfortunately, functional urology never got that kind of an importance. I'm glad you are taking it forward. But Sanjay, my first question directly to you on the practical aspect of incontinence is urinary urge incontinence and stress urinary incontinence, and that mixed bag of incontinence where a woman wakes up, where one actually comes n number of years later after the other. Clinically, would you take us through this important differentiation for all youngsters and colleagues about the clinical differentiation guidelines moving forward?
Thanks. So for the rest of the evening, if you need to refer to me, you can just call me Sanjay. And for Dr. Pandey, you can say Professor Pandey. So just to differentiate the two Sanjays in the panel. Jokes aside. So whenever you encounter a woman who complains of a history of incontinence, the first and foremost thing we want to do is to get some direction as to what is the type of incontinence this woman is suffering from. So the first is it an anatomical problem? Let's say, has she developed a VVF after a hysterectomy or something? Or is it incontinence happening through the urethra? And most often a history will tell you that. So once it's incontinence through the urethra, and an overwhelming majority of women will have incontinence through the urethral meatus, then it should either be a stress incontinence, as Dr. Pandey has told you, or an urgency incontinence, or some form of a mixed incontinence. Very rarely you could have what's called incontinence associated with chronic retention, where a woman has an overfull bladder and dribbles urine, typically in people who got neuropathies, for instance, and so on. So if the hallmark of stress incontinence is that the leak happens with a physical exertion, so a cough or a sneeze typically, or lifting a heavy weight or change in posture can sometimes trigger incontinence. The hallmark of urgency incontinence is that there's a symptom of urgency before the leakage happens. If a woman says that she has no urgency preceding the leak, she has no premonition that she's about to leak, and she does an activity and leaks simultaneously with the activity, the odds are that this is some form of a stress incontinence. But if she says that she gets a premonition, that she has an urgency, and that's followed by a leakage, then it's likely that it's some form of an urgency incontinence. Unfortunately, many women have mixed pictures. And if you carefully question women, almost 90% of women will complain of some form of complicated incontinence, so that it's not just a stress incontinence, but there's some element of urgency, voiding difficulty, and so on. So if you're careful in taking a history, you'll find that often the history overlaps. So a clinical exam can help you. Doing a physical examination and what's called the cough stress test. Typically, we do it with the woman lying down in the lithotomy position with the legs apart, the labia spread apart, and you are visually trying to look at the leakage of urine simultaneous with the cough. And a positive stress test implies that the leak starts with the cough and the leak ends with the cough. If the leak starts a fraction of a second after the woman coughed, or the leak continues beyond the end of the cough, this could possibly a cough-associated detrusor overactivity incontinence, which is a form of urgency incontinence rather than stress incontinence. Sorry, it's a long answer, but I hope that I've been able to tell the gist of it.
Yeah, so you did differentiate that, and that's very important. You know, they always say mixed incontinence is most prevalent, or possibly it becomes more prevalent because a woman attempts to come when it becomes most bothersome. That means one was always there, the other added upon, and she is in her prime of life, absolutely doing well. Grad, actually, this is incredible and inescapable, unique session on a Monday evening. Let me just confess that we are on the 18th minute right now, and we've got 375 colleagues joined in from all over the country. I think it's looking good. We are listening to the masters in medical communication on the subject of pelvic health. And I'm going to ask Dr. Sanjay, help us on this very continuum of how to investigate these kind of individuals who are coming in agony of incontinence of urine. Give us a broad approach. Take your time, please.
So first and foremost, for a vast majority of women, urinary incontinence is not a health hazard. So for an overwhelming majority, it is a quality of life problem. And hence, the woman should be bothered enough by the symptom to deserve some form of assessment evaluation. So when the woman comes, you need to differentiate, is she just looking for a reassurance that there's no health hazard here? Or is she truly looking for something to be done for the incontinence? Because there's a group of women who will just come to you, say, I've got a leakage. And the moment you tell them that, okay, this is not a health hazard, they say, okay, it's a very minor leakage. I don't want anything done. So that's the first and foremost. It's a quality of life problem by and large. Thereafter, in the assessment, we need to understand what's the degree of bother. So unlike, say, if somebody comes to me with a stone, where I know the stone is there, I can see is the kidney at risk. Here is the problem bothersome enough for the woman to require treatment. So if it's bothersome enough, then in that case, we would assess the woman in terms of what is the incontinence, what form of incontinence, and in general, the basic underlying fundamental principle, non-invasive evaluation before non-invasive treatment. So if you are planning to give non-invasive treatment, which is the way forward to start with, you would never do invasive assessments. So the initial assessment, the USI guideline says, assess the degree of bother, do a bladder diary to quantify the incontinence episodes. And a bladder diary gives a wealth of information regarding urinary incontinence. So you can see whether the woman has fluid overload, does she drink too much of water, does she have nocturnal polyuria, which is aggravating it. So I won't go into the details of it, but a bladder diary is a very critical piece of information when you assess the patient. A urine examination, especially if it's a short-term urinary incontinence. Some forms of bladder problems, specific one diagnosis which I'd like to mention here is carcinoma of the bladder, sometimes can be a flat lesion. And the only symptom that the woman may suffer from is urinary frequency, urgency. And in such women, if you've not done a urine examination and demonstrated microscopic hematuria, you might miss a bladder tumor because the ultrasound scan may be normal. Our guideline on the basis of expert opinion and weak levels of evidence suggests checking for the post-void residual in such women to make sure that they have a good voiding efficiency. So if the woman has no voiding difficulty, is emptying her bladder well, has primarily got urgency associated leak, is not having a fluid overload on the bladder diary, then the way forward would be initial attempts with conservative care. And the conservative care consists of bladder training, pelvic floor muscle training, counseling regarding lifestyle, talking to them about having less amount of the Araku coffee, and thereafter reassessing with their bladder diary and a history to try and understand how well they respond. If they respond well, nothing to be done. Don't respond well, we ask them, do you feel the bother is such that you would like medication to be used? And then for urgency incontinence, to make it very brief, we have two classes of medication, antimuscarinic and Meera, which is a beta-3 adrenergic agonist. They have different class actions in terms of their side effect and efficacy. Both are efficacious drugs, probably equivalent in efficacy, and the combined effect is more than the effect of either drug alone. If they've got stress incontinence, then we would teach them pelvic floor muscle training. This typically does not require any special devices for most women. So 5 out of 6 women will be able to learn the pelvic floor muscle training just on the basis of your clinical technique of teaching them. PFMT is defined in our guideline, and the key part of the definition in the guideline is that the PFMT must be supervised by physical exam. So if you just tell what is PFMT to the patient, that's not PFMT. It could be anything else, but not pelvic floor muscle training. So if you use the phrase pelvic floor muscle training, it implies that you've put your fingers into the vagina or the rectum. You have verified that the woman is contracting the right set of muscles, and when you tell her to relax, she relaxes the right set of muscles. You've used your other hand to make sure she's not contracting the abdominal, the gluteal, and the thigh muscles at the same time. And then you teach her rapid contractions, flicks, sustained contractions and the neck maneuver to do it before any anticipated increase in intra-abdominal pressure. With this, if they respond well, fine. If they don't respond well, and if it's bothersome enough, then you might consider doing an operative procedure for the woman if she's not still having her incontinence resolved by these methods. And one last line, for any woman who has a mixed presentation, which is very common, the dictum is always go for the urgency component first. So regardless of which is the dominant part, even if the woman says she's got dominant stress incontinence, our guideline very clearly states that treat the urgency component first, because the treatment for urgency is typically less invasive, much simpler, carries no long-term consequences, and hence you'll always start with that one first. Sanjay.
Awesome. Good one. So while we were soaking in the persona and the easing of the subject that you people are taking it forward, I'm actually enjoying it. Thank you so much for this. All three of you actually had in your opening statements talked about the very patient who presents to you. That is what our colleagues in the audience today want to look at. The very presentation and the reassurance which you do while talking positives in the history, I think probably opens up the Pandora's box of treatment. It actually does half the job already done. To me, at this point in time, the patient is saying, my life is my message. What Mahatma Gandhi said. He led by example. I think we need to lead by these examples and understand the agony that these patients go through. And very rightly said, Dr. Sanjay, every life matters. And therefore, you're attempting to improve the quality of life of these individuals. So getting back to you, Dr. Meera, while others have a cup of coffee, is about looking at this important aspect that you did talk about in this. Are women more likely to suffer with this problem, number one? Definitely. Because the pelvic issue is something which is maybe changing with age, changing with hormones, changing with pelvic floor changes and multiple childbirths. And what advice would you give to those women who could be at risk? Or what advice would you give to your youngster colleagues in gynecology who are looking at how to preventing one which could be iatrogenic? Yes. So who could suffer and what could be the way to prevent, both for patients as well as for colleague gynecologists in the audience?
Yeah. Generally, women suffer more thanks to the physiological insult and injury due to pregnancy, labor, traumatic delivery, and further worsened by multiple vaginal births and the insult of menopause, which happens to relax the pelvic floor muscles. And if they have added further insults like manual labor and have not taken adequate precautions of avoiding lifting weights and have not done the correct PFMT, which is supposed to be done by every single woman after the first delivery, irrespective of the mode of delivery, lifelong, every day, this would not happen. However, there are patients without any specific history of an instrumental delivery, big baby, or a complicated delivery, some to the effect of even 10 to 15% can have an obvious fecal incontinence, especially to flatus and liquid stools. So unless we probe these patients, we are not going to get this history. And if we investigate them further, in about patients who have had forceps delivery, up to a third can show demonstrable anatomic defects, especially on the endoanal ultrasound when we look for the sphincter complex. It's such a simple investigation where you have a demonstration of the mucosa, the internal anal sphincter, the external anal sphincter, and you can look at the levator ani as well. If the external or the internal anal sphincter is lost, it demonstrates as a defect on the endoanal ultrasound. And if it's encompassing more than a quadrant, that is a major defect, and these patients present with these symptoms. External anal sphincter is the voluntary muscle, we all know that, and contributes for the squeeze pressure. So if somebody has an external anal sphincter injury, they will be telling us indirectly that they are having fecal urgency and not able to control liquid stools. If it's an internal anal sphincter injury, it's under involuntary control, it's a smooth muscle, and it's under the sympathetic resting tone. So contributes to the resting tone, and these patients will have passive soiling. And if we have missed an internal sphincter injury at delivery, I think we have missed the boat, because then we cannot repair that injury. It is a very important aspect when we counsel these patients later on when they see us, saying that I am not going to be a miracle doctor and I'm going to make you 100% continent. That will not happen. There will be some degree of incontinence even after the repair is done.
Got it. That's great. So you talked about endoanal ultrasound. You looked at the evaluation part, the history, and the fecal incontinence aspect also gives you a lot of idea about what is it. Are there any medications for this? Is there anything?
It's about lifestyle changes. Continue with the pelvic floor physiotherapy. We have a very good pelvic floor physiotherapy team around here. We incorporate biofeedback because these are the same things which we would do for urinary incontinence. Some improvement is seen in that. They should restrict the fluid intake because that can make diarrheal stools. And they also can be given loperamide, which can make the stool consistency better, and avoid things which will cause irritable bowel syndrome. And as I said, if we demonstrate a significant defect and the anal manometry also suggests the squeeze pressure is deficient, then we can go ahead with the sphincter repair surgery, which is a procedure which can be done.
Got it. So I gather that while you are going to look into extreme degree of conservative measures for patients, at the same time taking them into confidence for an approach towards a possible surgery, I'm just taking a break from you and going to Dr. Vidya. Dr. Vidya, we did talk about female sexual dysfunction, and it was important for us to know that you said 40% of Indian women may be suffering from some kind of a female sexual dysfunction. Could you just elaborate for the sake of gynecology and urology colleagues, because it's all about partnership in infertility and sexual dysfunction? Could you just give us leads about what kind of practical scenarios that you've seen or the kind of disorders you've seen?
So I think first we have to understand what is female sexual dysfunction. I mean, what the definition actually gives an idea. So it can have 4 components. One is the whole effect of the desire, whether the woman has the desire for a sexual activity. So any dysfunction in this, whether she has a problem in arousal, whether she has an arousal, whether she has the desire, but she's not able to attain the orgasm. And lastly, whether she's experiencing pain, because this is the most important factor which actually brings us to us. So these are the 4 components that we look at a female sexual dysfunction. Again, as I said, these are all quality of life problems. So they usually come with not a problem of sexual dysfunction, but as we have fecal incontinence, we have urinary incontinence. So this part of sexual dysfunction is never displayed. It is after probing and asking them leading questions, that's when they open up and they say, yes, it is creating problem for us. So as I told you that 40% of the women do have this, but it's only the 10% who will come with this problem. So it is very difficult. It's very challenging as a physician to pinpoint. As I told you, there is no investigation that can tell us a patient has sexual dysfunction. It is only by history and probing that you learn about her sexual dysfunction.
Got it. So it's all about ask, make them aware, and then investigate. Meera, go ahead.
Yeah. I would like to make a point, just like Dr. Vidya said, the patients with fecal incontinence, though they will not come with the incontinence, they will come for recurrent urinary tract infection. They will come for recurrent vaginal discharge. They will come for dyspareunia. And then we find out this could be the cause. They will come for excoriation. They would think it is a dermatological condition. So,
friends, we are in the 27th minute of this Monday evening motivated meeting. And I gather at this point in time, we have got 520 colleagues who have joined in around from various parts of the country. I'm thankful to all of you who are motivated, because it's a potent medicine with the power to kill. And that's when you actually partner each other. So that's what it's all about, partnership today. Deep within every woman, there is that going through very tough days. Am I audible? Meera, am I audible? Yeah, sure. So deep within every woman that she's going through such tough days, it's important for that big baby rattling under her to come out and say, I'm living with incontinence, I'm living with sexual dysfunction, I'm living with a problem of situation of fecal incontinence. But Vidya, I was taking it forward and looking at this important aspect of, are there any medical conditions causing female sexual dysfunction? Are there any medicines which cause, like there are in male sexual dysfunction, there are all these anti that we use, antipsychotics, antihypertensives, name it. And men go through that dysfunction and we possibly want to withdraw, we can't withdraw. What's happening with female sexual dysfunction in medications and medical conditions?
So when we have a patient who has a female dysfunction, as I said, probing, asking questions. So yes, we will definitely ask her for any medical illness. Most important is any thyroid disorders like hypothyroid. Diabetes is one of them. Any neurological issues, hypertension. Patients who are on antihypertensives like beta blockers can have their impact on the sexual inhibitions. So these are antipsychotics. So you have to probe into her past history, where she may probably not give us a history of any psychiatric treatment or any psychological problem, because many people don't really come up with these kind of history. So you need to really get into the history, ask her whether these medications are being taken. And yes, these do have impact on the sexual activity. They decrease the desire and arousal phenomena. So we may need to partner with their doctors and modify the drugs. And of course, illness as age is a big factor. It's an independent factor for sexual dysfunction. So we have to probe into that. Yeah.
Absolutely. Got it. Actually, quite impressive. We can see that so much of agony, anguish, so much of dilemma, discontent in their personal lives, and the pain and agony, which is more in the mind and brain and body. They're also sometimes suppressed and may not be able to speak to you unless you are in proper privacy. And then you take the question forward. I think it's quite a combined teamwork. Like in erectile dysfunction, we sometimes look at the partner questionnaire, etc. Good enough. I'm very impressed. It looks very good. So as we move forward on this powerful message-giving issue, we're getting back again to Dr. Sanjay and looking at this important aspect of treatment of these patients. We did hear from him a conservative approach and the words called pelvic floor therapy and bladder training. Dr. Sanjay, this Indian guidelines happens to be historic in many ways in terms of, for the first time, be able to speak, do not in some issues and do in some issues. We like the audience to know how are we unique in Indian guidelines in terms of having brought those important points which was always missing in somebody else. So India marched forward with those important first times in the guidelines, which will express it to the large population around, and then take us through the therapy part on the conservative part. You did talk about those two important things. And let's highlight that, because there are physiotherapists, there are physiatrists in the audience at this point in time, apart from we who hardly know anything on pelvic. Go ahead.
Sure. So there are several aspects which are discussed for the first time in the Indian guideline, and the Indian guideline is different. So just to give you a little bit of background, all guidelines across the world are essentially created on the basis of the same global evidence. So the evidence base is typically the same. We look at the evidence, we look at local evidence, whatever is available. We then match it up with the socioeconomics, the healthcare infrastructure in each different country. And that's the basis on which each country has a different guideline despite it examining the same set of evidence. So many people asked us, why do you need a separate guideline in India? The reason was an Indian guideline, India is a different country. It has a different healthcare system, different socioeconomics, and hence the same evidence would yield different set of guideline recommendations. So some of the new things in the guidelines is, first, for the very first time now, we have a prevalence data regarding urinary incontinence in women from India. So we are always given to say in India, you ask about the prevalence, anything, and we say we don't have Indian data. Well, we do have Indian data. So when we searched, the data was buried deep inside literature, but we ultimately found 9 cross-sectional door-to-door surveys from Indian cities and urban areas which dealt with urinary incontinence. And on the basis of these 9, we have now a prevalence estimate, which is between 10 and 42%. We didn't combine this into one statistic because the different papers had slightly different definitions and age groups and so on. But we now have prevalence data for India for the first time. And this is now officially in the guideline. That's the first thing. We have 4 new definitions in the guidelines. And when I say new, they're either entirely new or there are certain key additions made to the existing international definitions. Now, one of the key additions I told you was regarding pelvic floor muscle training, where I told you that there is a requirement that you must verify by physical exam to call it PFMT. The second is an entirely new definition defined for the first time, and that's bladder training. And the reason why we defined bladder training in the document was we published a year before the guidelines were published, a survey from urologists across India. And we showed that the utilization of bladder training by Indian urologists was much lower than what it would be expected to be for patients with urinary incontinence. And I'm sure if you were to look at the gynecological practitioners, you will find that probably the utilization is even lower. And the reason we felt was that a large number of urologists were not really familiar with what bladder training is. And giving a definition, which in one line captures the essence of what bladder training is, giving a definition we felt would go a long way to resolving this. Because if you know a definition, if you're familiar with a definition, you automatically understand what it is. And that's the first step in utilizing the treatment. So just to summarize at this point, what bladder training is, it starts with the bladder diary. In the bladder diary, and this is primarily meant for urgency incontinence patients. So let's say the bladder diary shows that the woman goes every 90 minutes to pass urine on an average. Then from the bladder diary, we get this information. We tell her, instead of going every 90 minutes, you go by the clock every 80 minutes. So you go at 80 minutes before you get a strong urge, so that you can go with control, with full control over your faculties. You can amble across to the toilet rather than run to the toilet to avoid an incontinence. So the first step is gaining control back over life. So go every 80 minutes. And then every week, try and increase it by 10, 15 minutes. You can give them a target. And if they feel an urge before they are supposed to go, use urge suppression techniques to increase the intervoid interval until you reach a socially acceptable goal. So this definition, which was there in the bladder training, we felt this would go a long way to improving the utilization of bladder training in the management of our patients. The third definition, which modification of definition which we have is again a very critical modification, especially dear to Dr. Pandey's heart. And that is the definition of refractory urgency incontinence. Because Dr. Pandey is one of the leading exponents of botulinum toxin in bladder. And we know that refractory urgency incontinence is the indication for using botulinum for a patient who has urgency incontinence.
Yeah.
The existing international definition only came from one source, and that was the American guideline from the American Urological Association. But if you look at that guideline, that definition is deficient in several ways. And the two main places we found it deficient was, first was, how do you define that the patient has not responded to medication? So the AUA definition is that the patient should have taken OAB medicine and has not responded in 12 weeks. We made it mandatory that you must have used a combination of two different classes of OAB medicines, the antimuscarinic and mirabegron, before you label the patient refractory. And there's good evidence behind this, because we know that the combined therapy is more efficacious than either drug alone. There's level 1 evidence from multiple studies. And the second is, there's also studies to show that in women who were on antimuscarinics and who were planning for botulinum toxin or sacral neuromodulation were offered mirabegron, many of them choose not to go for the invasive management. So we know that the combination is more efficacious. So it does not make sense to label a patient as refractory if they've not used the combination. So that's the first major change in the definition. And the second major change is the requirement for examining a bladder diary. Now, this is very important, because I have seen personally patients who have been injected botulinum have been sent as patients non-responsive to botulinum toxin, and a bladder diary shows 5 liters of urine output in 24 hours. That makes zero sense. True. Zero sense to be injecting botulinum or putting a sacral neuromodulation in a woman who produces 5 liters in a day. And many of us are not able to tell how much urine we produce. So if you actually look at the chart, you'll not know. And this was mentioned in the first AUA guideline document in 2012 also, but they never incorporated it into the definition. So the guideline panel of the AUA also mentioned that we have seen anecdotally a significant proportion of women get therapy for invasive treatments for urgency incontinence, and they don't have a bladder diary. But in their judgment, they chose not to include it in the definition. I won't go into the reasons for that, but it does not make sense. So in our definition for refractory includes the requirement of having examined a bladder diary. So these are some of the important changes in the definitions that we have, the existing international definitions. Now, in terms of the do not recommendations, there are 2 do not recommendations in the guide. The first do not is, do not do a diagnostic cystoscopy. A diagnostic cystoscopy is almost never ever required to make a diagnosis of incontinence. So it's different if you suspect some other condition, you're looking for something else. Even there, cystoscopy is almost never a fishing expedition. You almost invariably know what you're looking for when you're going in. And most often the cystoscopy gets combined with a therapeutic procedure. So a diagnostic cystoscopy is usually not required. Our own survey showed that almost 30% of urologists across the 25%, if I remember correctly, across the country were doing a diagnostic cystoscopy. It's a do not recommendation. And in fact, from South India, we were the biggest culprits because almost 45% of South Indian urologists responded that they would do a diagnostic cystoscopy. The other do not recommendation is a sign of our times. And this is a sign of industrial pressure on urologists and gynecologists to do treatments. And that is a do not recommendation in terms of use of lasers for stress incontinence. There is a move by a lot of people, or a few people, to use lasers for stress incontinence in the absence of any background data in terms of a good sound theoretical model behind it, animal experimentation behind it, clinical experimentation behind it. And without all that, people have jumped into doing lasers for stress incontinence. Is a do not recommendation, that you should not be using it except as a research tool, as a part of a research protocol. So we are not saying don't do research on it, but you should not be using it in clinical utilization for your patients. I know I've taken a long time already, Sanjay.
So I just wanted, Sanjay, that's great actually. I just want to look at one important aspect, is that could you, for your youngsters, tell us, now that we are spoiled for choice with so much of medical management, you have a 25, 35, 55 and 75-year-old woman walking into a gynecology, urogynecology and a urologist clinic. Can you just take us through the choice of antimuscarinics versus Meera background? A very important confusion to be cleared today on a Motivated Monday.
Right. So for a vast majority of patients, the choice should actually is you could use any of the drugs. So I would actually tell you in all humility that for the vast majority of patients, you should be choosing the cheapest drug. And most urologists do not know which is the cheapest drug. So the new thing in the guideline is there's a table in the guideline for cost of therapies. So because we know that for a vast majority of people, the side effects are a class action. They're similar between most of the molecules, except for some few things, which I'll go into in a moment. Their efficacy is also similar. So there's not much to choose between efficacy and side effects of these drugs. So use the cheapest molecules and you can check which is the cheapest in your area. That's the first thing. Now, there are some subgroups of patients in whom you want to avoid certain classes of certain molecules. So if the patient has already got a cognitive disturbance, for instance, in that kind of a patient, probably the use of beta-3 agonists like mirabegron is a better choice as compared to an antimuscarinic. But if you do have to use an antimuscarinic, then certain types of antimuscarinics have not been shown to cause cognitive disturbance, specifically darifenacin, trospium, and solifenacin. These have very less propensity for causing cognitive disturbance. But even with these molecules, there is some long-term concern that if you use it for 10 years, 15 years, and so on, will we create some long-term issues in terms of cognition in elderly individuals especially. Now, those who have a problem with their voiding efficiency, say if they've got a somewhat reduced flow, they've got some elevation in their post-void residual, those kind of patients are probably better not offered an antimuscarinic. A beta-3 agonist, mirabegron, is a better choice for those kind of patients. If they've got a history of urinary retention in the past, if the history of delayed gastric emptying, or if they have a narrow angle glaucoma, or if they suffer from myasthenia gravis, all these patients should not be offered an antimuscarinic, should be offered beta-3 agonist. If the patient has uncontrolled hypertension, if the patient has a history of recent cardiovascular events or cerebrovascular events, I would avoid using mirabegron in these patients, and I would use an antimuscarinic in these patients. If the patient is a frail elderly individual, I would be cautious with all the molecules, but I'd probably veer again toward using mirabegron in these patients rather than the other drugs. If the patient is on digoxin, I would probably use antimuscarinics because we need a certain amount of dose adjustment of digoxin. The effect of digoxin gets potentiated, so you need to start with a low dose. So exercise caution, or use an antimuscarinic if the patient is on digoxin. So it's not a contraindication, but you need to be careful. So other than this, probably you can use any drug for your patient, use the cheapest one. If the patient has side effects, but other than, so we know that some patients have a lot of problems with dry mouth and constipation. Those patients should be started on mirabegron by and large. So I think in a nutshell, hopefully I've been able to answer that.
So nice. So we stand really on the shoulders of giants who actually lifted us at this point in time to the medicine that we practice today. I remember There were two articles in World Journal of Urology from the Japanese group and another journal, which finally talked in 2012 and 2016 that cognitive dysfunction was a huge aspect, not mentioned by pharmaceutical companies and investigators in that era. And you used to get people in their 40s to 60s where you would use the erstwhile or the good drugs. Patient would get a good effect, possibly with antimuscarinics in the urge, incontinence, urgency, but they would get cognitive dysfunction. And then when they would come and see Dr. Sanjay Pandey and Dr. Sanjay Sinha, we probably did not know so much on the cognitive dysfunction, or we would brush it aside, not knowing too much till those articles came up around and we understood that we were only giving them a modest therapy. We're giving them a good therapy, which we thought so. We could only give them this much and possibly not this much. So today we stand tall. So I think this was a very candid, very, very casual conversation with very strong statements that you made in from the don't know conversation like everybody around. And let me just confess here that I take a cue from the don't know. This, if I love you are the three most important words in the world at this point in time, which are so important to our life. I don't know are three most important words in medicine, which are so underused. And you rightly said so. I'm thrilled about this. We are moving ahead. Dr. Meera, we are actually moving to you. And when we talk about surgery, every patient wants medicine for surgery. They want medicine for fever. They want medicine for tumor. They want medicine for obstruction.
Absolutely.
So every surgeon carries with himself a small amount of symmetry, where from time to time he goes to pray. It's important for us to remember that a place of bitterness and a place of regret, where he must look forward to an explanation of all his failures. This is from your tweet, Dr. Sanjay Sinha. This is on 21 October 2019. I can't forget this because when we operate too much.
Got very good memory.
I mean, I've been following him every dawn and every night. So imagine when we operate more, possibly we may see more complications. But also practice makes you perfect. That practice which has actually happened around is making you people so powerful in preaching the subject, which is going across to close to 672 people who have logged in at this point in time, which is awesome at this point. IPCA talk show, thank you so much for organizing on a Monday evening. Monday is the start of a day where we are a little fresh compared to the week that we spent with so much, which was all agony and attributes around. We get into depth of Tuesday, Wednesday, Thursday, but I think this point in time, we're good enough to go for some more time. And Dr. Meera, we're coming to that important surgeon in you that I did quote from this important aspect from Dr. Sanjay's quote. So let's look into that. When will you offer a surgery for fecal incontinence? That you are a master in it. What will you tell a patient about fecal incontinence surgery, your success rates, world success rates, and what surgery it is?
Sure. Typically, as I don't know is a very important phrase for people who practice medicine. We need to know when not to operate as a surgeon.
So
that is the first establishment in a case of fecal incontinence, because we need to understand that the fecal incontinence is first of all presenting at a remote period from actual insult, number one. And we need to categorize whether it's anatomical, whether we have a functional element to it, whether we can prove both, and if not, what is the reason for the fecal incontinence. Unless we have this with absolute dogma, I would not touch the patient for surgery. As very well we know from the literature and experience, I can only guarantee 70% success rate, and the success rate comes down with time and repetitive surgeries. So the first shot should be the best shot, and it is the best shot. And over time, the success of that also can regress because of the adding on insult. So the second point is when not to operate. These injuries can not only damage the pelvic floor, but also can cause pudendal nerve compression and a neuropathy, which in turn presents as laxity and fecal incontinence because it's H2, S3, S4. If it is a pudendal neuropathy, the patient will not show any anatomical and physiological disturbances, but will show the squeeze pressure not to be great and an internal sphincter deficiency as in the resting tone, but will present with incontinence. So if I'm not able to establish an anatomic defect on the imaging, I should not touch this patient for surgery. This patient will be a candidate for PFMT with biofeedback and a cautious, guarded prognostication. And if they are refractory to surgery as well, they will be good candidates for sacral neural modulation. And the surgery is anatomically putting back the sphincter together with a proper dissection going to the lateral ends, identifying the sphincter just like we would do it in a primary repair. Thankfully, because of the scarring, it's all not that bloody, but we cannot identify the internal anal sphincter separately. We have missed that boat. It merges with the scar tissue, and then you have to do an overlap technique with a delayed absorbable suture. Never use a permanent or non-absorbable suture like
good point.
Because there will be knot migration, there will be sinus or fistula, there will be dyspareunia, and there will be infection, and the patient will literally have pain in the bum. That is something we should not give her. So delayed absorbable suture, because the integrity holds on it for 6 months rather than a 90-day. So these are some of the important aspects of surgical repair. In refractory cases, we can go in for gracilis repair. I've seen only one case with my colorectal colleague, but otherwise the sphincter repairs have been fairly successful with a 90 plus 95% continence rate. So that is good. If they are refractory or it's a pudendal neuropathy, they will respond to PFMT with biofeedback, and refractory cases to SNM.
Yeah, she's only 29. You cleared her fecal incontinence. She is asymptomatic. She wants to ask you questions regarding sexual activity and future pregnancy.
Sure. Sexual activity, definitely go ahead. But if there is dyspareunia, again, educate them. Discuss with various positions she can adapt to address the dyspareunia. Lubrication, very, very important. Pelvic floor relaxation in this case, because sometimes the tightness of the vaginal orifice might be there. So that is very, very important. The second point is future childbearing. If the patient has had a tear and is not repaired, she can go ahead with another vaginal delivery and comfortably get it repaired later. But she's had a repair and opting for a vaginal birth, I would be dissuading her because it will damage the repair. And she should be going for a planned cesarean section.
Got it. Friends, you are with Dr. Meera Raghavan from Apollo Hospitals, Chennai. You're with Dr. Vidya Bandukwala from the Nanavati Hospital in Mumbai as gynecologist. And partnering them are two Sanjays from Hyderabad and Mumbai. Moving forward to this important aspect of sexual dysfunction, I heard two terms from you, leads me to Dr. Vidya, dyspareunia. Dr. Vidya, you want to open it up? What is vulvodynia? What is vestibulitis? What is vaginismus? And what is dyspareunia? Just to open up the subject before we get into that pain difficulty. So we are going into painful sexual disorder, and just get into that, please.
Yeah. So when I told you about sexual dysfunction, I mentioned the genital pain, the sexual pain, and this is where we have vaginismus. So basically, vaginismus has two components. One is it has a primary and a secondary. Primary is the whole idea of, so you have a female who is probably absolutely fine. You know, she just has a phobia, a sexual phobia for anything penetrating into her. So these are patients who probably may not give you any history as such, but when you ask them to be physically checked, you typically see them that they go onto the examination table, but as soon as you're even trying to go closer for a pelvic examination, you can see them involuntarily going to a spasm. You know, they literally pull up their buttocks, squeeze them. It's like us seeing a pelvic floor muscle training. You know, how do you see them? So they pull themselves up. And these patients are typically the primary, where there is a phobia. The phobia is so deep that they will not allow any pelvic examination. So in these patients, very, very important is to talk it out to them. And even if you're doing a physical examination, you need to explain every step. Some of the patient will probably allow you to, but I think in the first meeting, they may not allow you to have a physical. So I think we should not force them. We should try to make them more comfortable and probably ask them to come later, be a little more prepared for the session. So these are primary. Maybe they have a psychological impact as a child. They probably had some sexual abuse, some difficult relationship. In that way, they have an impact on the primary reasons. The secondary vaginismus are patients who probably had a sexual intercourse and suddenly with the probably recurrent
post-childbirth.
Yeah, post childbirth.
Episiotomies and all. Yeah.
Like I would put Dr. Meera's case here, where she's had a repair and that has healed with the fibrosis. So she could definitely have a scar tenderness here, which dissuades her from having a sexual intimacy.
Got it, yeah.
This is secondary to an underlying cause. So primary is there is not really any cause, but secondary is 100% there is a cause, and we will need to work on that. Now, how do we deal with these kind of patients? As I said, it's a lot of counseling.
True.
In India, we probably don't have a dedicated counselor. So we need to fill the gap. As a gynecologist, as a urogynecologist, I think we need to work by talking to them and taking them into our confidence. So I think that's where we go. And then the physical aspect is to let her know the sexual anatomy. Why would she, again, there in vaginismus, there are patients who get provoked by the idea of a sexual intimacy, but they're able to insert a tampon, they're able to have a speculum examination, but the idea of sexual intimacy may just not allow them to do so. So there's a lot of counseling that goes in these kind of patients. And as I said, if it is a secondary, then you definitely need to know the underlying cause. Like even a urinary incontinence could be a problem, where patient doesn't want to have any intimacy because of the cause. So we need to work on that.
Got it. So it's all about counseling, reassurance, easing her in your clinic, maybe involve a partner for a partner participation, giving her a self-belief and rejuvenating her back to what she deserves is all that we're looking forward to. We're also looking at the pelvic floor issue. Yeah, go ahead.
It's about having a counseling session, not just with the patient, but also with the partner.
Yeah.
Patients, their partners always feel rejected.
Yeah.
And that could distance them further, so the interpersonal relationship is also hampered. So it is very important that not only we counsel her, but counsel the partner. We need to open up the whole box and tell them that she is undergoing a problem and you need to be a part of support system.
Terrific. Got it. Completely got it.
We will go a little later. You need to also partner with a psychotherapist. You need to have a physical therapy.
Absolutely.
And we are looking at PFMT as Dr. Sanjay very
yes.
Elaborated. Here we are looking at relaxing methods. So
Absolutely. So relaxing the mind, relaxing the body, a psychosomatic issue crept deep into her habitat, sadly, something where you need a partner participation. You rightly said it goes beyond it. So two of you are fighting right now for pelvic floor therapy. I'm very impressed. These therapies are not known to urologists and gynecologists, and they are completely getting ingrained in our system. Glad we are conversing on this. But Meera, you want to make a quick point?
Yeah. After Dr. Vidya.
Answer one thing is your reassurance and realistic goals are very important. If you tell them that, we're going to make you fine in a day or two or a week, I think that is wrong. We need to tell them that
very well said. Very well said. Yeah. Meera, you want to make a point on this?
Yeah. I also want to make a point where nulliparous women who are just married and getting into it also can have fecal incontinence, and we need to think out of the box. Invariably, these patients sometimes present to gynecologists, and the usual assumption is it's a Bartholin's abscess or a Skeen's abscess or a labial abscess. Do not touch it, because it could be a perianal abscess with a perianal fistula and can develop into a rectovaginal fistula. The imaging should be proper. You need a colorectal buddy with you. Do not assume it's Bartholin's abscess, especially if it is recurrent, if it's multiple, and it's a younger patient and obese. They could be suffering from fissure in ano, recurrent perianal abscess. I've seen two interesting cases. Both of them presented with a rectovaginal fistula after being operated as thinking it's a Bartholin. Either of them did not have a MRI done. And one was turning out to be a Crohn's disease, and the other one was TB.
Yeah,
this is not uncommon. So don't venture out thinking it could be a Bartholin's, it could be a perianal.
Got it. So you're attempting to actually improve pelvic health of women. And when we are talking about discomfort right now, we moved on from reassurance and easy presentations to discomfort and pain. Let me just come to a little bit of pain at this point in time. We could be in early 40s and 50s at this point in time, and we understand we don't have that important aspect which we're going to talk about called nocturia. And I was given a chance to look into this important subject. When we go into our 60s and 70s, we'll remember this Monday evening when we did talk about that we'll gracefully age to a point in time where things will creep inside and the warding diary will talk about getting up multiple times at night. It gets very difficult. Imagine your father and your grandfather at this point in time getting up with Parkinsonism and arthritis as the new friends that he has, or mother or grandmother. And they actually are getting the lights on, lights off while we snore in the bed and think of something else. So unless you go through it, you possibly don't understand what it is. Nocturia is a situation which happens to all age groups, but more common to those people who are elderly and geriatrics, where they've got more friends in life which they never wanted to. They got established themselves and they go through the agony of getting up umpteen times at night, good enough that they sometimes keep the pot close to them. Sometimes they wear a condom catheter if there are males around and whatnot. So that agony of old age which comes around, which is not alone with nocturia, but with multiple things. And then you have got your medicines, you've got diseases, you've got beverages, and you've got diabetes. You've got more friends in life at that point. And so nocturia is something where we never thought of. We're talking about quality of life issues. That's an issue which we possibly forgot. Way back at Kokilaben Hospital 3 years ago, when I was just about to speak on the inaugural meeting of inaugurating this clinic of nocturia and bedwetting combined together as the first country's clinic of both combined. Please believe me, I had got English slides created half an hour ago, and the 12th hour, I was walking up and an elderly lady in her late 70s just walked up close to me and said, "Beta, jara Hindi mein bologe, humge Angrezi nahi aati hai." I looked up and saw the hall was jam-packed, close to 700 people, and I was talking to people who are needy. That's why they had come in to look at the inauguration of a fancy kind of a clinic, which is going to address them around. So looking at nocturia as a very important aspect of elderly people, and I am happy at this point in time to have served for 3 years on isolated complaints of nocturia and bedwetting in youngsters and elderly people, a quality of life issue which has not been taken care of, possibly because the subjects are missing, possibly they are relegated to the last day of all the conferences, and possibly because the pharmaceutical companies in India did not look into in a big way, or maybe our textbooks did not have more than a paragraph of each of these subjects. So these are important subjects of nocturia and bedwetting, where women and men go through, and when they're elderly, they go through the real life experience, which sadly no one wants to go through. Old age has got its own friends around. We also heard about pain. So I must talk about pain before I give you a breather to move ahead. Let's talk about bladder pain syndrome, a subject which is again shrouded so much in agony. When we look at two important aspects, urinary tract infection on one side and overactive bladder on the other side, we know there are a lot of mismatches around and cross communications. If you have a secondary overactivity as a result of an UTI since yesterday night, you've got a frequency urgency kind of a situation which you never had. Compared to somebody who has got a discomfort and pain in the pelvis, where a bladder filling is so uncomfortable. Sadly, most of them are women. Sadly, because they possibly have not taken it forward and lived for months or years on this problem, they then go to our colleagues in gynecology who outnumber us 10 times more. We have 5,000 urologists to 50,000 gynecologists in the country. It is very important for us to actually address our gynecology colleagues that while you look at female pelvic health and pain, you look at endometriosis on one part and you look at pelvic spasm on the other part, where our physiatry colleagues do a wonderful job on the pelvic floor and health. It is important not to forget that if a woman complains of chronic pain, pressure, and discomfort in the region of the pelvis, accompanied by urinary symptoms, which is so enumerated well in the guidelines as urgency, frequency, and urge incontinence, and she has got a quality of life which is completely in cocoon, the bladder is possibly moving in a different direction. And this bladder may sometimes, in a small phenotype of patients, land up with possibly an end-stage bladder, where I and Dr. Sinha would land up actually doing augmentation or substitution cystoplasties, which could be the end-stage bladder. So diseases of that kind which lead to an end stage is a situation which women suffer with. Unless we make an awareness, and ask them, possibly we'll miss out. And these patients have been unfortunately wrongly treated with hysterectomies and TURPs or as recurrent UTIs and medical management. Friends, we are looking at the guidelines, and I'm very proud today to be looking at guidelines are meant to address the broader subject of the subject which has come to a fore. And let me assure and probably enthuse all our colleagues today, all of you who are our 694 actually logged in at this point in time, that the guidelines are such important aspects, and it's known by the company you keep. So the company you keep is best known by the desktop you keep. And if your desktop has got the right stuff, and I think my desktop has got the USI guidelines, and I assure Dr. Sanjay for having given us that. So all of you who practice female pelvic health, who practice urinary incontinence and functional urology, when it comes tomorrow morning, you should have your USI guidelines on your desktop. When you're free between patients and having the Raku coffee, you should look into these guidelines, because these are the most structured guidelines across. While you read them, Dr. Sanjay has also requested for you to give feedbacks to the USI and to the team. We will only get better when we have versions after version. That means the team which created the guidelines actually made it move forward. But Sanjay, we heard from you refractory urinary urge incontinence. Tell us that we have actually exhausted our medical management on an individual and she or he is refractory urgency incontinence. She comes to you and you need to move up and get her dry. So she could either be an OAB dry or an OAB wet, urgency or urge incontinence. Take us through on invasive management as to when you consider and how do you consider them.
So the first thing I would do is I would re-examine the diagnosis. So it's important to make sure that we are not missing something. Let's say it's not, some form of Parkinsonism or MS or something manifesting as OAB. So re-examine the diagnosis, make sure that the patient has been compliant with therapies, is not overhydrated. So you've gone into all those things and you find that she's still having refractory urgency incontinence. Now we are looking at what to do next. So if the patient fulfills the criteria for refractory urgency incontinence, as per the guideline, we have two different methods of recommended management for these patients under the Indian guideline. The first is use of botulinum toxin into the bladder, which we as well as Dr. Sanjay Pandey has a lot of experience with, and perhaps I will ask him at some stage to tell about his experiences. And the other is the use of sacral neuromodulation for the management of these patients. Again, we have experience with this, but very expensive, difficult to manage to do in our patients. There's a third method of managing these patients, which is not part of our guidelines at this point in the guideline, and that is use of percutaneous tibial nerve stimulation. So the PTNS stimulation in our guideline is part of the regular conservative physical therapies. It's not specifically a part of refractory urgency incontinence, although it is a part of the refractory urgency incontinence in the AUA American guideline. The reason why we did not keep it here is we felt that the quality of evidence for PTNS in refractory urgency incontinence was not good enough to justify putting it at that point in the guideline. So for these two methods of managing botulinum toxin, sacral neuromodulation, very briefly, if the patient has already an element of voiding dysfunction, so she's got elevated residuals, poor detrusor contractility, or if the patient has associated other pelvic floor disorders, for instance, chronic constipation, then sacral neuromodulation is probably the better way to manage the patient. If the patient has got cognitive dysfunctions, difficulty in handling devices and so on, then sacral neuromodulation is not a good method for managing the patient. Under the guideline, a USI guideline, we have recommended that you should do a urodynamics evaluation before treating the patient with invasive therapies. Again, our guideline is unique. This is a unique recommendation based on low level, level 3 evidence, although we actually have level 1 evidence, but the level 1 evidence is not of good quality. So we downgraded it to 2 steps to level 3, and it's a weak recommendation. And the reason for this weak recommendation is because we have found that many patients who are referred as refractory urgency incontinence might have an alternate diagnosis like voiding dysfunction. And it does not make sense to do a complicated or expensive therapy or, take the patient to the OT and inject botulinum when the patient has something totally different. And we have, from our own survey, shown that availability of urodynamics is not an issue in India today. So it's easily available. You can access it.
Yeah.
So botulinum, typical recommended dose is 100 units. Maybe I should ask.
No, go ahead. Keep going ahead. Okay. Wonderful. Keep it on.
So the key thing to discuss about botulinum with the patient is, number one, it's not a permanent therapy. The effect of the injection will wear off after a period of time. Because it's a smooth muscle, typically the efficacy lasts between 6 to 12 months. The injection is invasive. You do it in the operating room using a cystoscope and inject directly into the bladder wall. It's expensive. And some patients can develop urinary retention. Now, with the 100 unit recommended dose that we have for overactive bladder or urgency incontinence, retention rates have been described to be about 5%. So it's a relatively small retention rate. If you inject higher dosages, for instance, 200 units, the ballpark figure is 20%. Although a recent randomized trial between sacral neuromodulation and BTX showed that the retention rate was about 8% or so, but certainly more than 5%. So it's a dose-dependent increase in the risk of retention when you inject botulinum. And the retention may last for several weeks to months. So if it happens, you need to counsel the patient that if it happens, she would need to do self-catheterization. Now, in this difficult to manage group of patients, when you inject botulinum, you expect that about 2/3 of women will say that they are much better. If they are looking for absolute dryness, not a drop of urine leaking out, that may not be more than 30-35%, about 1/3 or so. So again, you have to be careful in the patient's expectations, as Dr. Vidya also mentioned very earlier. Patient expectation management is very, very important.
Absolutely.
Problems. So they must be clear about what to expect. But a significant 60 to 70% of patients, 2/3 of patients will say that they are much better with the therapy. So you need to counsel them about this, and they should be willing to come back for repeat injections as required. I won't go into the technique of injection. That is something that can always discuss it.
So the audience has actually got that. There is this word called refractory. The definitions did change as time went by, as evidence came. We evolved into the new definition of failing two drugs. And therefore, very important before you put them into a minimally invasive therapy or you label them as a refractory, very rightly said, you would look at re-evaluating them completely. It starts again with history, geography, re-evaluation. Prove to yourself that you are getting into a picture. And as I rightly said, urodynamics has its own role to look at that. This was for a much fitter, younger patient, Dr. Sanjay. Would you like to look at anybody else, a geriatric woman? A woman of that age group who has got dementia, who has got CVA. Her one son lives in Dubai, other one lives in the United States of America. And she has got her OAB concerns. She has got her nocturia concerns. So this is of that age group where we all will gracefully age to at some point in time. Please address us and our problems 20 years later.
Right. So this is the most difficult group of patient to handle. And some of these patients will have not just an incontinence issue, they will also have a muscle which has become weak. So when they try and pass urine, they don't empty well either. So it's a combination of what was originally called as detrusor hyperactivity with underactivity. So they have poor contractility. So they have got overactive bladder or urgency incontinence. At the same time, they don't void very well when they pass. And that can actually aggravate the storage symptoms because the effective bladder capacity comes down because they're leaving behind urine in the bladder. So a difficult to manage group of patients. The other thing that happens here is that because of cognitive defects, some of the issues in managing them become a problem. I think the most important thing here is the bottom line. Who is bothered by the incontinence?
Absolutely.
First thing that I will look at this is, I will ask, is it the patient who is bothered or are the family members bothered? I think that's the very first question to ask.
Absolutely.
Many times with these patients, is the family members who are bothered. I would never treat the patient to solve the agony of the family member.
Absolutely.
So if the patient is not bothered by the incontinence, obviously we would try simple things for everybody. So it's not to say that you would treat the patient, but I would not do very aggressive management to solve the symptoms of the attendant. So in those kind of situations, I would look to containment devices, use of diapers, use of even catheters for a woman who's not emptying well. These are not ideal situations. These are not ideal solutions, but nevertheless, they are important solutions to keep in mind. So use of an indwelling catheter. In some situations, use of a suprapubic catheter, although we know in the long term, the complication rates start matching each other. But in the short and medium term, the suprapubic catheter has less complications. And use, as I said, of containment devices are excellent in managing these patients. Many of these patients who have got reasonable cognition can get managed by, say, a drug like botulinum or with which does not cause cognitive dysfunction. If you're using botulinum, in some of these patients, I would choose half the dose. Inject 50 units instead of 100 units, especially if they've got poor voiding function. So that's another thing I would look at because they would have a higher propensity to get into retention. Maybe I can ask Sanjay what he does. Would you choose a lower dose in some of these patients? What do you?
Yeah, so again, that's a trade-off between a lower dose, matching them, you are re-evaluating them more frequently, which will not be possible. So that little catch situation, when we look at that frail elderly patient or a couple who are taking care of each other, it is a tough situation where we will be keen to look at every aspect that we would given. By Hippocratic oath, first do no harm, but do good to them. Doing good to relatives who are youngsters and probably bothered about their own sleep is a different aspect. But if they're living at a borderline of a high residual volume and not bothered, we would look at counseling them, making them aware, and looking at that borderline high residual volume does not go higher because they become PQ or become constipated. So very important for us. We look at their other aspects improve. While we look at not letting them go out there. So Sanjay, I'll just take a break from you. Can
I just add one point before we move on? In this particular group of patients, it's important to remember that incontinence can be the presenting symptom of a neurological disorder. So some patients may present with incontinence for the first time because they've got multi-system atrophy or MSA, or they may present because of NPH, normal pressure hydrocephalus, with incontinence. And it's important to involve your neurology colleague who is experienced in managing these patients, because sometimes it's difficult to pin the diagnosis. But managing the NPH, let's say, for instance, by doing a CSF drain, may improve their cognition, may improve their incontinence also. So just to make sure that you remember that there's a neurology angle to these diagnoses.
Absolutely. So you said V is stronger than I. That means more of I is joined to make a V. And as a teamwork, we could pick up those things which may not be in our domain all the time. So as A changes, those things do add up. Dr. Meera, I'm coming to you. We are using the word refractory to move ahead. We just heard the word refractory in urinary issues. Let me come to you, Dr. Meera, and talk about this important options available when there is a refractory incontinence of the kind that you are dealing with, even after surgery or when surgery can't be offered. Refractory incontinence in a woman very young and geriatric. Can you just wrap it up?
With fecal incontinence.
Yes, that's right.
Yes, a refractory incontinence in a woman who's young, probably the quality of life is so disturbed, she will be a candidate for sacral neural modulation. Definitely. And if surgery is not been offered or could not be offered, like your pudendal neuropathy, which is an aftermath of the delivery itself. And in a geriatric patients, containment devices with special special attention to skin care and educating the carers, especially for the back sores. This is a very, very common problem. I recently saw an 86-year-old lady with extensive excoriation in the pudendum and the perianal area because of double incontinence. The carer was blissfully using briskly all the wet wipes and literally taking off her epidermis as well. So that should not be the case. They can be educated properly. Zinc oxide cream is a very good method to heal off those areas and protect those areas from repeated excoriation. So containment devices, avoiding acidic foodstuffs, alkalinizing the urine, hydration, and loperamide would be in cases of refractory. And as Dr. Sanjay Sinha said, if they are having tremors, they would not be candidates for sacral neural modulation, especially from that point of view. And contamination can also be a problem in these patients. So that's very, very important.
Got it. Thanks so much. Let's start this. Let's just confess that we are on the 70th minute and we have got 750 colleagues joining together. If it is a Monday and you're so motivated, then let me tell you that you are on a big flight which has got 770 people on board. There are 4 pilots, 2 are gynecologists and 2 are surgeons. I'm sorry, we are going overboard. The plane will not land in Hyderabad so soon, and we are probably moving towards few question and answers which comes in around. Friends, I think we are still on the word refractory. Dr. Vidya, we are on the word refractory. We heard the refractory word from Dr. Sanjay Sinha. We heard the word refractory from Dr. Meera, who's sitting in a music room. And then finally, we'll look at refractory vaginismus. Tough one. Refractory vaginismus is quite a situation. You did counseling, you reassured her and a partner, and you looked at everything around. You also looked at a physiotherapist and a clinical psychologist. You have got a labeled refractory vaginismus. Go ahead.
We probably even can help them with their self-therapy where you have vaginal dilators. We ask them to insert, but somehow they're able to do all that. But when it comes to sexual intimacy, they still have the phobia. So I think in these cases where you fail all the treatment, I think you are one of them who has used botulinum in vaginismus refractory. Yes.
So let me just come here, just to interrupt you. We heard you and Dr. Sanjay Sinha talk so passionately about pelvic floor therapy. For colleagues in the audience and urology and gynecology, that we may have got time to learn the technique and trick, which is so really mentioned in the guidelines. We may not have time, and therefore we'll team up with our physiotherapists and physiatrists back home in our institutes. It's a wake-up call for all of us in pelvic floor therapy or in pelvic floor wellness that we're talking about today. When we did talk about the refractoriness, we also heard about the word called botulinum toxin from you and Dr. Sinha. So let me just come in and pitch in for a short while, and then I give the floor again to you. Way back 2006-07, Dr. Pasek, a plastic surgeon in the United States of America, was coming up with this important project, which I was also a part of, which was refractory vaginismus way back when I was in Sri Ramchandra Medical College in University. We had 2 such patients where there was no dose defined. At that point in time, the urology world was moving forward in dose-defining study in neurogenic detrusor overactivity and in idiopathic overactivity, which is 200 units. But there was no dose defined off-label because there was no clinical work on that. Try to believe me that the early days across the world on refractory vaginismus, in an attempt to do all that, my gynecologists have actually stood in the audience and confessed and said, we have done episiotomies, we have done dilatations, we have done whatnot across the world. We looked at injecting botulinum toxin into the pubococcyges, into the pelvic floor, and looked at what dose. Nobody knew the dose. I even did not know where to inject anteriorly or posteriorly. The injections are all lateral and semilateral, but we also injected anteriorly and posteriorly. Believe me, lo and behold, 2 to 4 weeks later, both these ladies way back in Chennai came with fecal and urinary incontinence. This was amazing. This was talking about the drug being actually acting, but they were in more agony than before. Here, I knew that this effect is temporary, as Dr. Sanjay said, it never lasts forever. And therefore, I kept on running away from them and reassuring them. Era changed when Dr. Pasik came up with guidelines, was a part of that US FDA work and trial. Believe me, Allergan, the erstwhile company Allergan did complete the trials with US FDA, and that's very much out there at the NIH. The issues will come up soon, and they have defined the dose and defined the workaround. So refractory vaginismus is truly all about identifying the truth of the moment and probably loading them at the right dose, again with partner participation and workaround. So those guidelines and those tricks and techniques are actually loaded in Dr. Pasik's work. He, being a plastic surgeon, took this gauntlet upon him and was the first US FDA approved doctor to be injecting it in the United States of America. It still happens to be an off-label indication, but 7 gynecologists came in with their cases back in Kokilabin Hospital and learned the injection, and they've actually mastered the art as much as you were talking about. So just giving you an idea that though botulinum toxin has got off-label indications, like it also happens in detrusor sphincter dyssynergia, where we inject into the external sphincter, and out there the effect is only 3 to 4 months compared to detrusor, where with wonderful technique, Dr. Sanjay Sinha is able to stretch it to 6 to 12 months even, whereas 6 to 9 months has possibly been. So it's all about the practitioner, about the technique and stretch around. So I think this wonderful drug, which is called as botulinum toxin, the word toxin needs to be removed. And therefore, there are 2 such companies in the world which make it. One is the famous A for Allergan, which has been doing it for last more than 2 decades. And way back in India, we have I for Intas from Ahmedabad, which took up this Make in India campaign and brought this drug to India. A shade cheaper, but equally effective. I have not yet randomized it. I was confessing that to Dr. Sanjay in one of the meetings around. But we have looked at vis-a-vis patients who took the first injection on Allergan's botulinum toxin, got the second and third injection from Indian botulinum toxin. We looked at the effect. You really can't compare effects at different points in time. Summer and winter and monsoon may be different, but we have compared their effect and found that we are no less. So Indians are no less. They have actually come up with the first guidelines that we are moving ahead. Vidya, you want to add anything on the refractory vaginismus? I'm moving ahead on the next step.
About it, so we can move on.
Yeah, so there we are. We are looking at little important aspect. And Dr. Sanjay, would you like to just clarify for so many colleagues in urogynecology and gynecology who actually have joined in around on that aspect where they will be asking this? OAB symptoms with POP, is POP causally related, making a diagnosis, and then approaching both OAB and POP as approaching this final frontiers in incontinence.
We are into the last 3 minutes, but let me try and be as brief as I can. So we know that the only symptom that correlates with prolapse consistently is a feeling of bulge. But the fact is that when women have prolapse of significant degrees, many of them have voiding, inefficient voiding. Many of them leave behind substantial residues. It alters the anatomy of the pelvic floor. So patients who've got prolapse often will not pass urine well. They may have voiding dysfunction, poor streams, elevated residuals, and so on. And all this can contribute to symptoms of overactive bladder. So there may be women who have got symptoms of OAB with pelvic organ prolapse. There may be women who have stress incontinence, which is either masked or overt along with pelvic organ prolapse. So once there is pelvic organ prolapse, it makes sense to try and understand what happens when you reduce the prolapse. So especially if the woman is having a significant residual or she's got stress incontinence, I would reduce the prolapse and assess this woman whether reducing the prolapse improves the voiding efficiency. So we keep pessaries in our urodynamics lab and we put the prolapse back, put a pessary, make the woman pass with the prolapse out, with the prolapse in. And very often you can show that once you put a pessary in and then you've done the same study, you find that woman now passes very well, much more efficiently. Those kind of women obviously will respond in terms of improvement of the urinary symptoms when you take care of the prolapse. The other way around is not necessarily true. So we've seen women in whom the prolapse is out, you've put the prolapse back in, you've tried to do another study, you find that in the next study with the prolapse in, the problem has not entirely gone away. But yet when you operate the prolapse, they've actually improved their voiding efficiency. So I would say it's not always the other way around. But if you put the prolapse back and she starts voiding well, you know for sure that treating the prolapse is going to do well. She's going to do well. So if she's got symptomatic prolapse, I would say anyway treat the prolapse and tell them, let's see what happens. If it's not a symptomatic prolapse, especially if the prolapse is only up to a stage 2, I would be very cautious in attributing the symptoms to the prolapse. So lower stage prolapse, those kind of patients, perhaps the prolapse may not be causally related to the urinary symptom. And there I would probably aggressively manage the urine symptom first and see what happens. I don't know whether I've been able to do that. Quickly tell you what you want to.
You did very well. We're just opening to questions and I'll put some comments from all of you, but I just want to take one question from Lucknow. Directly to you, Dr. Sanjay, is what kind of food should be suggested for OAB patient? We're looking at the behavioral therapy. Just want to transgress that point again.
So the only things we know for sure is excess amounts of caffeine-related products are a problem. So tea, coffee, alcohol, colas, cut down. Water, excess, cut down. For the rest, it's more or less an individual thing. So some patients may say that this particular food substance, spices don't suit me, and if I take it, I get more problems. These are very individualized. The patient says, I have a problem with this, fine. But otherwise, there's no universal recommendation to cutting down any of the other food substances to my knowledge.
Got it. So in OAB, food, the caffeine was one which is a bladder irritant and which also works at the level of kidneys, apart from coffee and alcohol and tea, which causes more diuresis. So kidney producing more, bladder not able to hold, you are in trouble around that. Coming to that very important aspect you led to, it is different from bladder pain syndrome where a patient comes and says, मैं जब ये खाती हूँ या वो खाती हूँ तो मेरे को I take dark chocolates and coffee and lemon and I got discomfort around. Bladder pain syndrome also gets another diary called the food diary. The food diary is a part of that important aspect where those foods which aggravate the already disappearing gag layer and the pancystitis which is happening to patients of bladder pain syndrome is another aspect we need to look at. So all of you very passionately did hear your patients around and did counsel them and take it forward. So hearing out the patients, taking out their voiding diaries to understand the report cards, whether it's true or false, gives us a subjective and objective phenomena. To quantify it and to prove to themselves 2 weeks and 8 weeks later that they're getting treated. The phenomena is getting treated. And same things happen even in bladder pain syndrome, where you do the pain scoring, take it forward and treat the vicious cycle of pain, discomfort, bladder filling, forced overactivity, forced urgency, etc. So I think it's quite a situation we are going through in female pelvic health when we actually open up the Pandora's box. The next question comes from Dr. N.K. Sharma from Jalandhar. It's to you, Dr. Sanjay. Is Silodosin effective in old age to women who are unable to empty their bladder? Your take on this whole alpha blocker range for women of old age where their bladder.
So unfortunately, the quality of evidence with regard to use of alpha blockers in women with voiding difficulty leaves a lot to be desired. So there are some individual studies suggesting that it's useful, many others suggesting that it's not. I can give you an overall impression that I have from the evidence as well as from my own experience in using the drug, that for a vast majority of women, the drug does not work. There's a very small subgroup of women who actually have a primary bladder neck obstruction. This percentage is small, but it is not zero. So there are some women who do respond, but by and large, there's some women who subjectively say they are better, but if you objectively check, you find that there's absolutely no difference in their flows, their residuals, and so on. So I would use it if a woman has voiding dysfunction, but I would give a short trial, try and see whether she really improves. And if she doesn't improve, I would stop it. So for a vast majority, I'd say it doesn't work.
That's right. Absolutely well said. Dr. Meera, there's a question for you in terms of, I have got low stamina and strength. I used to be a runner. Now I don't get up so much around. Number one, I had a twin delivery recently vaginally. 3 months I was fine. And then this is the doctor speaking, and I now find temporary fecal incontinence. That means she has now found fecal incontinence. You want to add something to it? You want to help her out by a teleconsultation right now?
Definitely. Ask mainly by the twin delivery vaginal. How big were the babies? Was it an instrumental delivery? How long was the second stage? Use of epidural? And how were the symptoms immediately? Does she have alternating constipation, diarrhea? her diet, and overdoing of her fluids. Because she's an athlete, she might be hydrating herself obsessively as well. And the fiber in the diet. Tone down on the fiber, try to restrict your fluids, but don't go into a constipation mode, because that will aggravate the problems.
It'll aggravate those problems.
Definitely start doing pelvic floor exercises. It's just not the delivery aspect of it. Twin is double insult to the pelvic floor just by pregnancy on its own merit. So pelvic floor exercises might be the key to stop the delayed presentation of the fecal incontinence. And is she incontinent to form stools, liquid stools, or flatus? So rigorous religious pelvic floor exercises might be the key to stop the incontinence which has happened, and she will be able to do it.
Awesome. I got it. I think we all got it. Dr. Vidya, somebody has asked a question which I wanted to ask seriously. You talked about an off-label indication in vaginismus, but that's the only way you could treat a patient. You would not give her an episiotomy and more stretches and dilatation. You did talk about this important refractory vaginismus. You want to take us through the result of this patient or the patients who have been treated with refractory vaginismus in short?
Actually, I could relate to this refractory vaginismus. I think you probably know this patient who you treated with your botulinum, and she came to me and we had a fertility treatment going around and she got pregnant.
Wow.
Treatment. So I think with refractory cases, botulinum worked wonderfully, because I think that relaxation that she got after that and the counseling made a lot of difference. Plus, we taught her how to calibrate her vagina with the dilators. That helped her to overcome the fear that something going in can be managed. So all that calibration and this counseling did help her. So I think it wonderfully works when you team up. It's not just just working on a medical concept. It's working psychologically as well.
Awesome. Friends, we have just got news from ATC Hyderabad that the sky is cleared. The 4 pilots are now keen to take you and probably land you in the city of Hyderabad. That means you all 800 people on board. I think let me confess, you people actually have done awesome. With the strokes, which is so subtle and so surprising, the kind of subject that you touch it with very candid conversation or very practical points. I salute each of you for 2 reasons. One is, 72 hours ago, when I called you up and said, would you join this? Would you be a part of this flight, which we're going to fly together? You never said no. And Dr. Sanjay, you have never said no to me in 13 years. Since in Kolkata conference, you took me for a coffee side and said, what are you up to and what are you doing? And since then, I have not looked back. Thank you so much for those words of advice, which many of us taken. So I've taken that word of advice and put the USI guidelines to my desktop. It is my request as a urologist that we should be proud of it, and everybody should have it on its desktop tomorrow morning. Looking at that important aspect. To the ladies, Dr. Vidya and Dr. Meera, sitting from your office and from your music room, respectively, I think I must thank you for what you have done today. You actually opened up the subject quite candidly and very practically. Subjects which are difficult because you do great obstetrics, gynecology, laparoscopy, infertility. But when you open up subjects of that kind to colleagues who may be juniors, who may be starters, who would take up the subject beyond, which has been taught to them by clinicians and by their teachers, and they're passed the exam too. Many clinicians in the first 5 years, let me confess, look at creating some niche areas and banners. I am a specialist in this. I wish and look forward to those master classes and webinars that they're going through, that they polish them, and then probably once the lockdown opens, they reach the destinations of the teachers where they could learn the practicals aspect of it. For example, Dr. Sanjay Sinha, who does his own urodynamics and looks at the urodynamics graph and always teaches and says that a picture transmitted by a telemedicine or a picture frame of a complete urodynamic studies may not be able to tell you all that. You've got to look at the patient and then probably use an investigation to move forward. So a single big adverse event of just looking at an investigation and diagnosing a patient may not be right. It may be good for a bladder tumor, a growth, or for a renal mass 3 to 3 centimeters and tell the treatment. But for just looking at urodynamic graph, just looking at an ECG and not knowing it's a 20 or a 90-year-old patient would be quite difficult. So as I come to a close, I have so many questions, but I understand that we are sitting on a Monday evening with dinner with our family, and it's important that we start the week very well. So we started the week very well with a great Monday morning work. We all were inundated with work is what it was, be it telemedicine, be it some of the emergency surgeries. And then we moved forward to quite a absorbing session. I have a stroke of luck where I could actually look at all of you having agreed to and come on board. And that was only because IPCA decided to look at no slides. So IPCA Pharmaceuticals, you thought of this important process. Thank you for thinking about this, because this actually changed the whole scenario. We could look at the body language of each of them who were absolutely significantly talking about the positives on the subject. So a patient who comes with difficulty of anguish, desperation, and agony of subjects, which is going wrong in diapers or in diapers for fecal or urinary incontinence or unconsummated or secondary vaginismus, or a bladder pain syndrome with a vicious cycle of bladder pain, bladder filling, forced frequency, getting up at night with pain, not with frequency urgency, are phenomena which happens to people at all age groups. These subjects have got a vast age group from 20s to 80s. And I gather that anybody who sees you as specialists today in the audience and all three of you as co-panelists, it always is you are the nth doctor and the last doctor they want to see. That means they are tired of seeing it. It's important for therefore us, each of us in this August audience today, which is 800 plus, that we have a very smooth landing in Hyderabad at this point in time, which means that I must thank IPCA Pharmaceuticals for having thought of this 72 hours earlier, for colleagues who have agreed to this, for all of you on Monday evening, 800 plus on board today, right now. I'm sorry I couldn't have taken more questions, but the questions are always there. We'll bounce upon each other on various meetings and conferences and take the subject much higher. So in my end is my beginning. We are going to close it right now with that T.S. Eliot. Dr. Vidya, your last words, I did not let you summarize. So just last few one sentence from each of you.
I want all of our colleagues who are listening to us today, thank you very much. But the whole thing is what we learned today, thanks to all the panelists and you, that it's always a team that works towards your patient. In the best interest, I think sometimes, as Dr. Sanjay Sinha said, I don't know. We have to realize that we have limitations and we need to team up with the right people for, in the case of female sexual dysfunction, we have the gynecologist, we have the psychotherapist, as well as the sex therapist, all work together. And we always believe that it should not be PFMT, it should also be relaxation techniques that we need to focus on. It's something which is underrated, overlooked. We really don't look into female sexual health. It's time that we look into that and we make it as a right for every woman to talk about it loud and clear.
So that you made it so loud and clear. And as a panel, we had youngsters in the whole audience, but we had seniors too. We had my teachers and we had colleagues who practiced this, and they were there more for looking and walking through this. I'm stimulated to look at senior teachers and audience who have got experience of humankind, who actually do teach us and probably take it forward from the pedestals of various meetings and conferences and operating rooms. Thank you so much, seniors, colleagues in gynecology and in urology who have come in on a motivated Monday. Meera, your last sentence, please.
Absolutely, sir. Thank you, IPCA, and thank you, both Sanjay and Dr. Vidya, for such a wonderful evening. I've always looked upon to both the Dr. Sanjays as my mentors, let me say, because physically distanced, and as an inspiration. And about fecal incontinence, very discrete, structured questioning is the key to clinch the diagnosis and know when not to operate. That is the most important thing. And offer the correct sequential therapy. Oh, that's very kind.
Well done. Congratulations to what you do. So sequential therapy of progress, Dr. Sanjay will remember that afternoon we had in Chennai. So Fevicon was great on August 2019. So you said sequential therapy, move up the ladder, agree to what you cannot do, but take it forward and handhold these patients who are for anesthetists to walk in after agony. Is that what you said?
Absolutely.
I would always leave the last stage to Dr. Sanjay Sinha. Sir, your last words before we close this wonderful meeting. Thank you so much. It's impressive show completely. IPCA and seniors, thank you so much. Dr. Sanjay will speak the last few sentences and give us those words of thought and moral wisdom. We are stimulated by the stroke of luck today. Your stage, sir. Please.
So wonderful program. I've enjoyed the entire session. I've really learned a lot listening to Dr. Meera, Vidya, and as usual to Dr. Sanjay Pandey. It's always a pleasure interacting with you all. The guidelines are available on the USI website, especially for the gynecologists. It's on the USI website. But if you have any difficulty, you can get in touch with Dr. Pandey or with me or any of your urology colleagues, and hopefully they can get it for you. Use the guidelines, quote the guidelines, refer to the guidelines, and criticize it so that hopefully we can come up with something better. Thank you all very much. 800 people plus, that's really real impressive, and we are really gratified to see that. Thanks, IPCA.
Thank you, everybody. IPCA, thank you so much. It's from heart of all these people who have landed on a very safe flight. The flight has landed. keep your seat belts fastened, but you can take a break and leave the meeting to come back again on another platform soon. Thank you so much. We sign off today evening, and we promise to continue to do better under Hippocratic Oath. Thank you, everybody. Please sign off and take a good break.